Okay, so we are today discussing the sequelae of the peptic ulcer surgery. Sequelae because there is more than two, more than one. So first the sequel which come across after the peptic ulcer disease surgery. First the recurrent ulcerations. Recurrent ulcerations means after that, even after doing the surgery for the peptic ulcer diseases, patient may again get recurrently that ulcers in the peptic in the same area or the area which are communicating means the stroma ulcer means where you anastomose part of the jejunum to the stomach. So at the junction of that, this anastomosis, there may be ulcer on the jejunum side. Okay, so means this recurrent ulcers is a common sequel or the complications that may happen, and that ulcers may again have some complications like the bleeding and the perforations. But if initially this can be treated, if you know there is a recurrent ulceration, patient have some symptoms, so these can be easily treated by this anti-secretory drugs, that PPI and H2 blockers. But the complications occurs when sometimes this these ulcerations erode or penetrates the nearby colon, and then they create gastrojejunopholic fistula. Gastrojejunopholic fistula means that you have did the gastrojejunostomy, and at that portion there is ulcer which penetrate the colon behind. Colon is in front of this, na? In the abdomen, the side, the relations is that the colon, the transverse colon is just in front of the stomach. So that in that area, that there may be that ulcers may penetrate to the wall of colon, and that is the formation of the gastrojejunal colic fistula. So what happens in this fistula? The characteristic feature is that when the patient has the gastrojejunal colic fistula after the peptic ulcer disease surgery, the patient have a history. Patient give the complaint of that diarrhea, severe diarrhea that happens just after taking food. When the patient takes food, at, at after few minutes, patient have to go, and there is a foul smelling diarrhea, and sometimes that vomiting also there. Vomiting also there, and the vomiting is a for is that vomiting is very severe vomiting with the fecal smell in that vomitus, because that colon is connected to the that jejunum, and that portion the fecal matter present in the colon comes into that jejunum, and with the vomiting there is the feature is that vomiting, severe vomiting that have foul smelling. So that is the one very difficult complications. uh, and to diagnose this, CT with the barium enema is the best tools to diagnose. Give the barium with the enema through rectal route, and then after that take the X-ray, so you can see that this is the communication of the transverse colon and to the jejunum part. So this CT is important to diagnose, and for the correction of this, the surgery is required to the correct. So just after the laparotomy, you have to separate the communication part, the fistula, and then the separate suturing should be there. Means the search, if anybody any patient has a sequel of that the surgery gastrojejunopelvic fistula, then surgery is the only options. This condition cannot be treated by the medicines, so that patient may require the revision surgery. Revision surgery means when as another surgery is required to correct the things occur before surgery, means previous surgery. So that is called a revision surgery. So that revision surgery may be required in these conditions. Next, the complication that sequel is that small stomach syndrome. Small stomach syndrome is it should be there because there is you have removed the half and three-fourths of the stomach, so the stomach will become very small. So the patient take the food, so the early satiety is there. In the gastrectomy, the below first and below two, you have to remove the part of the stomach, so stomach become small. And in that other surgery where the truncal vagotomy or the highly selective truncal vagotomy, you have denervated that part, so that receptive relaxation is not happened, because when we take the food, our stomach relax, but when we are just disconnecting the nerve, we have that part has the deficiency in the nerve supply, so that part fails to relax properly. So that early satiety means even if taking small food, patient feels fullness in abdomen, and the patient may not take enough food, so that small stomach syndrome is happen. So to treat this condition, you have advised your patient to take to take multiple meals in a day with a small amount. So that is the only things. But fortunately, these things correct itself with the time goes. These things becomes normal, and patient can adjust these things. Third sequel is the bile vomiting. Sometimes the patient after taking food, patient suddenly feel that some reflex symptoms, and the vomiting is there. So usually the vomiting contains the food with the bile, but sometimes the only biles may comes, because these things also happen because that vagotomy, the truncal vagotomy or the highly selective vagotomy, with the denervation of that duodenum, and that the biliary tree is also denervated. So that's why there is no the collection is there, and when you take the food, then it means the bile is continuously is coming from the food. There is no good control over their biliary tree. So that's why this biles comes into the stomach, and it comes with the vomiting. So bile vomiting is also very difficult condition to treat. Some medicines, bile chelating agents may be used initially but may not helpful. So to correct this, one revision surgery is required. That is by Roux and Y bypass surgery, or Roux and Y diversion surgery. That's called Roux and Y. We will discuss later that also we discuss what we do in that surgery to counter these sequels. Then next and very important, early dumping and late dumping. Early and late dumping, these are important sequels which few patients, not all the patients, but up to 5 to 10% patients always suffer this early and late dumping conditions. There are two different conditions: early dumping and late dumping. Early dumping means when patient take the food, and due to that in the vagotomy and drainage, or in gastrectomy, what we do, we have just removed the part of the stomach, and we directly connect the stomach with the jejunum. So what happened, the patient take the food, and that food with high osmotic value, because the stomach there is a high, the food is very concentrated, and it directly goes into the intestine, into the jejunum. So due to this high osmotic food comes into the jejunum, suddenly what happens, there is a there is a huge amount of the fluid is sequestrated into the intestine to correct this osmotic conditions, osmotic gradient. So due to this, the high sequestration of the GIT tract fluid comes into the the intestine suddenly to correct that to counter that high osmotic value of the food, the patient may suddenly goes into the hypovolemia because the circulating fluid it comes into as sequestration into the intestine. So that's why the patient suddenly feels that epigastric illness, sweating, lightheadedness, tachycardia, and patient may become faint, and sometimes patient may feel the diarrhea also because there is a huge amount of fluid that comes into the intestine. So these things may happen in the early dumping, means when the patient take the food and after the just immediate or just a few minutes the patient feels fainting and sweating and the tachycardia, and the patient may feel patient may go into hypovolemic shock. So this is the happen in early dumping. And the late dumping means that is another phenomena. The symptoms are almost same here, although patient become the faint, patient may be hypo patient may be in the shock, hypovolemic shock, and patient may feel tremor, faintness, means the symptoms are almost similar, but here the pathophysiology totally different. Here what happens when the patient take the food and after a few after 1 hour, so the fluid when it uh, highly concentrated fluid, especially the carbohydrate rich food when it comes to the jejunum, then there is the due to high glucose level in the food, there is a reaction, there is the stimulus of the pancreas to secrete a huge amount of insulin to control this high amount of the blood, high amount of the blood sugar. So this reactive increase of the insulin, due to this increase in the concentration of the insulin in the blood, patient may become may go into the hypoglycemia. Understand? So here is the reactive hypoglycemia in the late dumping, where the hypovolemia in the early dumping. So early dumping and late dumping, these are the two complicated the sequels which present almost the similar symptoms. Patient become faint, patient may becomes this lethargy, and patients may feel some sweating, tremors, but the pathology is totally different. So to correct this, what are the treatment? This is the treatment is also the revision surgery that usually these conditions are in very few patients, but some patients may become adjust to these conditions also. But if patient is not adjusting, then revision Roux-en-Y surgery, Roux-en-Y diversion surgery may be required, may be helpful in some conditions. Then the post-vagotomy diarrhea, it's also one complications due to that we have just denervated that part of the stomach to that vagus nerve. So due to that vagotomy, the patient may have that improper gastric movement, improper movement in the intestine. That's why patients may feel the diarrhea, and that diarrhea maybe some in some patient diarrhea become very explosive, very severe diarrhea. Patient may become dehydrated also, and this comes the conditions may present as episodics. And some patients may have the diarrhea of the feeling of the boiling water, means the very hot, the patient feel like the dilated food is very hot, and the boiling water. So these conditions also there, and these conditions also means can improve itself also. uh, but sometimes usually that antidiarrheal medicines and the advice to the type of food patients may feel relaxed, and surgery may not required. Next thing, the malignant transformations. Some patients, it has been seen in few studies that the patients after the peptic ulcer disease surgeries, the convert into the malignancies common in that patient. So this means that ulcers may become the malignant in some patients after the surgery. Then the nutritional consequences that obvious nutritional consequences must be there, because we have just disturbed the normal anatomy of the GIT tract, and so that absorption of that the nutrients is not proper. So due to that, we have to remove the some half and 3/4 part of the stomach. So there is the deficiency of intrinsic factor, so that proper absorption of vitamin B12 is not there, so patient may go into that pernicious anemia, and sometimes the patients may have some iron deficiency anemia, and some vitamins are not absorbed properly because the complete gut is disturbed, so that patients have some malnutrition in this in the after the surgery also. So if the patient has any patient has lose some weight, so it's very difficult to patient gain again the weight after that this peptic ulcer disease surgery. And next, the more common and common the sequels, that is the gallstones. So gallstones means that the gallstone generations, the production of the gallstone is common after this kind of surgery, especially this that vagotomy and highly selective vagotomy. Because when we denervated that part of the vagus nerve, so that includes the biliary also. So the bile is not is comes properly, means bile is not released properly from the gallbladder, and so that called the stasis of the bile in the gallbladder for the longer time. So that stasis may cause the production of the gallstones. So stasis is a very important factor in the generation of the gallstone. So these are the few complications of the sequels, not complications, sequels, which usually occurs after that the peptic ulcer disease surgeries, the Billroth first, the Billroth second, truncal vagotomy and drainage, highly selective truncal vagotomy and truncal vagotomy and entrectomy. So these are the sequels which present after the peptic ulcer disease surgery. So we are just again saying I'm the Ru and Y gastric bypass. So this is the Ru and Y gastric bypass. What we did here? Here we just bypass complete stomach and duodenum. We just directly anastomose the jejunum to the anterior part of the cardia, the cardia, or just directly from the esophagus. Means we just disconnect this part of the stomach and duodenum and directly communicate. So that complications which are occurs, that gallstones and sorry, the bile vomiting and early dumping, late dumping. So these, it has been shown that after doing this Ru and Y bypass, the patient may have relief in that features. Okay, so this is the, and some other conditions of that stomach, and the just like the gastric tumor, malignancy of the stomach, or the duodenum. In also that condition, you may see that this type of surgery, the Ru and Y surgery, is described various times. Okay, so Ru and Y, its name is actually the Rooks and Y, but it always means we had to say the name is Ru and Y gastric bypass. So it includes that the bypass of complete stomach as well as duodenum. We directly anastomose to the gastric pouch to the jejunum. Okay, so this is the kind of revision surgery which is used to do after that in sequel of the peptic ulcer surgery, and in some conditions of that stomach and duodenum, this surgery is prescribed. Now come to the complication of the peptic ulcers. So there are three major complications of the peptic ulcers: perforations, bleeding, and stenosis. Three major complications: perforations, where that ulcer is erode complete wall of that stomach, either the duodenum, and all the content of the stomach and duodenum comes into the peritoneal cavity. The bleeding is there. The the ulcer erode any the vessels in the base of that wall or in the base of that ulcer. Ulcer erode the wall of that artery or the vein, and then that called the bleeding. Stenosis usually occurs after the healing of the ulcer, when the deep ulcers penetrates up to the muscular wall, and after the healing and the fibrosis is there, and the fibrosis causes the construction of the muscles, that may cause the stenosis. So stenosis may cause narrowing in the lumen of that duodenum. So that is the complications. We will discuss one by one. Perforations. Incidents are usually these incidents of the perforations is usually very high before the discovering of these anti-secretory drugs. Since these drugs are there, so the incidence of that perforation has become very very low, because patient starts when the patient had any kind of this features of the gastric ulcers, and go to the doctors, and then the doctor prescribe these medicines, so that the chances of the perforation becomes very low. But it may happen also. The most common cause of nowadays the perforation is not the peptic ulcer, but the most common cause of that perforation nowadays is the intake of excessive intake of NSAIDs. NSAID drugs, these are the drug which have seen the function of the eroding of the gastric mucosa, the duodenal mucosa very severely. So what happens, sometimes only single tablet of the aspirin may cause the perforation. When the patient take the tablet, and if somehow that tablet is stuck in the wall of that stomach or the duodenum, so stucking there, it starting eroding the wall of, and that patient may have the perforations. So that's why if any patient require NSAIDs, so if you are prescribing the NSAIDs, you have to prescribe the anti-secretory PPI or the H2 blockers along with this NSAIDs always. Both gastric ulcer and duodenal ulcers can be perforated, but the common site of the perforation of the duodenal ulcer is anterior ulcer. We have already discussed in the kissing ulcer, the two ulcers simultaneously in the anterior wall and posterior wall of duodenum. So anterior ulcers are most common for that perforations, while the posterior ulcers are most commonly have the bleeding. So most usually the most cause of the peptic ulcer perforations, that is the anterior ulcer in the first part of the duodenum. What are the clinical features? When the patients have this perforations and patient comes to you, so usually the patient have the history of long time history of the having the peptic ulcer diseases. So you can suspect that patient may have these conditions, and usually the patient of this who is having long time history of peptic ulcer disease comes with a sudden onset of pain, and sudden onset of pain in abdomen, and there is the pain is generalized in whole abdomen. Patient may be in the shock also, and due to that release of the gastric content into the peritoneal cavity, so that the complete peritoneum, that parietal peritoneum becomes irritated and inflamed. So that inflamed and irritant peritoneum, that is the peritonitis condition. So the generalized peritonitis conditions causes the severe pain in the abdomen. The pain is so severe that patients may not bend or may not just move little bit also. Patient just lie down the straight, and the abdomen is just like the board, right? Usually our abdomen moves when we take the respirations, but because the severe pain in the patient will not take the abdominal respirations. Patient do only that the thoracic respirations, because the movement of the abdomen may cause the severe pain to the patient. So that patient exhibit the board like rigidity and abdomen, which the abdomen of the patient looks like the board. It will not move with the respirations. Patient is lie, and as the time passes, if patient is not getting proper treatment, that infection in the peritoneal cavity may goes into the blood, and that causes the septicemia. Patient may goes into the septicemic shock. So after the septicemia, patient may have the pyrexia. That's why pyrexia comes later, not early, because it takes 7 to 8 hours to develop the septicemia. Sometimes the patient may have some unusual symptoms also, just like the weakness and little pain in abdomen, the pain in the low in the thighs, some unusual presentation also there. Okay, so but the most of the condition, patient comes to the sudden onset of the pain in abdomen, and the abdomens become very hard, patient unable to move, and patient may have some symptom of the shock. And patients with who have the history of the peptic ulcer disease, then you must suspect that patient may have the perforations. Okay, so all the perforations that either in the duodenal perforations, gastric perforations, or the intestinal perforations, always all the patients have little bit difference, but the general symptomatology of the patient is same, because once that any area anywhere duodenum or that stomach is ruptured or intestine ruptured, that contents come to the cavity, and the whole peritoneal cavity become inflamed, and peritonitis become irritant and inflamed. That's called the peritonitis. So that peritonitis causes the similar symptoms in all the patients. That's why all the kind of the intestinal perforations exhibits all similar kind of the presentations. So next, the investigations to rule out this, that erect, you have to take X-ray in erect position of the patients. So you can see that gas on the diaphragm here in the right side. It means there is the perforation, because when the perforation is there, so the air is comes to the diaphragm. Usually no air is in the right side of the diaphragm. It may be you may see the little air in the left side, but that should be in the stomach. But here right side, if you see in that X-ray, it means there is the gas under the diaphragm. It means there is the perforation in the duodenum or the stomach. So but the CT is more accurate, especially the CT barium meal or the contrast material. Contrast CT is most accurately give that site of that perforations. Then the serum elevated serum amylase level and altered serum electrolytes. All the electrolytes altered because of that patient in the shock, and the patient have the septicemia. So all that sodium, potassiums, the electrolytes become altered. So this is the investigation technique to find out that the perforations. So we just stop here. Next class we just discuss that treatment.